back to Skinfluence. I'm your host, Dr. Dustin Portela, and today we have a guest episode with Dr. Michael Christopher. He's a board-certified dermatologist that practices in Tucson, Arizona. Dr. Christopher is an expert in dermoscopy. If you're not familiar with dermoscopy, it is a tool that we use in dermatology. You can think of it like the stethoscope to a cardiologist. The dermatoscope is to the dermatologist to help us look at lesions on your skin with greater detail and understanding to catch skin cancer earlier. Dermoscopy is something that's been around for a number of years, but over the last 15 has had more widespread adoption. And there's so much more information that many dermatologists can learn in the field of dermoscopy. And Dr. Christopher is an excellent educator on his social media about dermoscopy for other dermatologists. Our conversation starts with some of the physics of how dermoscopy works, so bear with us as we get through some of those details, but I promise that the juice is going to be worth the squeeze as we come into a larger discussion on understanding skin health, as well as how to approach screening for your own health. What is standard of care versus what is optimum to keep you healthy and vital for as long as possible. We don't just talk about skin, we're also getting into the weeds on things like blood pressure and other screening like colonoscopy and mammogram, because the screening recommendations that are available to the general public may not be sufficient for all people. It was an incredibly insightful conversation. I know it's one that you'll enjoy. So please welcome Dr. Christopher to the podcast. Dr. Christopher, welcome to the podcast. I'm glad to have you here and have this conversation.
Thanks for bringing me on. I'm happy to be here.
So we connected on Instagram. It's really only been a couple of months that we started following you, and I have been so appreciative of your education on a tool that we use in dermatology called dermoscopy.
Yes.
This is the stethoscope of dermatology. If a cardiologist needs a stethoscope, a dermatologist needs a dermatoscope. And I wanted to bring you on to help viewers and listeners to understand what this tool is, why we use it, and really why it's such a critical part of the work that we do as a dermatologist. And if you have any, I always think like if you're seeing a dermatologist that doesn't use this, I don't know, it makes me skittish. But that I don't mean to take away from the expertise of somebody that's been doing this for so long. But what is a dermatoscope?
So a dermatoscope is you can look at it kind of like I hate to use the term, it's a magnifying glass. It is a tool that uses magnification with illumination that allows you to see structures that are present within the skin. And it's important to kind of differentiate the kind of types of dermoscopy when we utilize that tool. So you have non-polarized dermoscopy and you have polarized dermoscopy. When you look at somebody's skin with your naked eye, there is reflectance, right, on the skin, and that will kind of scatter light back into your eye so you can't see structures that are within the skin. When you apply the dermatoscope onto the skin, when dermoscopy first came out, it was in, I think, the late 1980s, actually. They only had non-polarized dermoscopy. And so you always had to have a fluid interface applied onto the skin and then the scope attached or, applied to it so that you can reduce the scattering of light and refraction to your eye. But polarized dermoscopy came out, and that allowed us to see structures that are within the skin. And that's actually very important, in particular for things like melanoma, visualization of vascular structures, and you name it, basal cell carcinoma, squamous cell carcinoma, and using a dermatoscope that has both of those modes is essential. But using polarized dermoscopy really was to me the big game changer.
Yeah. Now, for the average listener who may not understand the terms, we're essentially talking about the light. The most probably practical application of this in the life of somebody is like the blue blockers or the glasses that do not reflect off the water. You see these late night infomercials where somebody's out fishing and then all of a sudden they show the polarized version where they put the polarized lens in front of the camera and you can see through the water and you see all the fish swimming down there. I don't know if you've seen those commercials.
I have, yes, correct.
But essentially that's kind of what we're trying to do is filter down to just the polarized light so we don't get so much reflective scatter off the skin. And just like the polarized glasses allow you to see into the water better, polarized light actually helps us to see through some of those skin layers into some of the structures that are happening, within that first millimeter or so of the skin.
Yeah, I agree completely. And it is like in our the tools that we use, almost every current dermatoscope that uses polarized light uses cross polarization. So there's two filters, and this really helps with the backscatter. The first filter, like putting on that first lens, that allows the light to come out kind of collimated and direct. But the second filter, they're orthogonal to each other. To see the structures that are deep within the skin itself, when that light is reflected back, it has to take like a 90-degree angle. And that filter, the cross-polarized component of the dermatoscope, that filter will only capture the kind of curved light that is coming back. So that is how you're able to actually visualize those structures. Like you're able to see the fish in the water. This is how you're able to see, say, shiny white blotches and strands that you would look for in a basal cell, or orthogonal lines that you look for in a melanoma that you see with polarized dermoscopy.
So when did dermoscopy experience widespread adoption in the field of dermatology? I started my residency in 2014 after my intern year, and we were trained in dermoscopy from day one, but it wasn't always the case. So when did this really hit mass market adoption inside the field of dermatology?
So here's the deal. I wish I could say that that's uniform. And that is the big issue with it to me, is that it is not uniform. I started residency in 2015. I had 3 lectures on dermoscopy, and that didn't mean that the dermatologists that I trained with, they were already board certified dermatologists. They use a dermatoscope, but the discussions of dermoscopy were very little. Like, okay, you see these, are large arborizing telangiectasias. That's what everybody likes to say about a vascular structure for a basal cell. However, for me, the way that I look at dermoscopy is it is as important as pathology. So as you recall, going to grand rounds, what would you discuss when you had a case? You would discuss the clinical presentation, morphology of the lesions themselves. Say this is an inflammatory condition, and you would discuss the dermatopathology, right? They would correlate very well. And dermoscopy would never be discussed. And I went to, University of Wisconsin, very good, institution. They did standard of care, and it was not utilized. So I would say, to me, that is one of the biggest issues, is that there's a requirement, but it is not enforced to look at that understanding. And this is something that's interfaced on patients every single day. Right?
Yeah.
So every time you see somebody for a skin check, you're putting a dermatoscope on somebody's skin, and you should be looking at all of those lesions with a dermatoscope. So we should be training on it. From my opinion, is much greater than what we're doing. So
I agree with you on that. I know that we were given dermatoscopes in our program. Fortunately, we were able to get a grant, and we got, I think at the time it was the DL3, which was a great dermatoscope. And we were, kind of just handed that. We did get a couple lectures on it, but it was more just like, all right, you need to start using this. And then when you biopsy something, you need to go back and think about, what did this look like under your dermatoscope? And it was a lot of self-education. So although it was something we were encouraged to use, I would say, similar to yourself, probably only a couple lectures a year, one of those being at like a big grand rounds, would they bring in a dermatoscope expert. And we often had lectures from Dr. T at the University of Michigan, who's very good on this stuff. And he's an entertaining guy as well. So I do think it's something that the education could be improved when it is such a critical tool. You can imagine no cardiologist without the top of the line stethoscope. And I feel naked without my dermatoscope. If the batteries run dead at the end of a morning, I'm like, I've got to go find a backup. And thankfully I have one, but it's something I can't function without. And I feel like I'm not serving my patients the way that I should without it.
I agree completely with you. I do. The way that I look at this is, for people that have not bought in yet on dermoscopy, and this is just reality, it still is very evident to date, and when it needs to be used, on what, when you need to apply to the skin. And if you look at a radiologist, the radiologist is never going to be learning just radiographs only, or, how to read a CT scan. They need to know how to look at MRI and all of that, because that's going to provide you data and information that one modality cannot provide you. and our eyes are great. We can see a lot of stuff. There's so many things that dermoscopy is not essential for. However, when it comes to skin lesions themselves, I have to apply it to, and this is my expertise. I'm an expert in dermoscopy. I have to apply it to so many lesions per patient to be able to tell that's a lentigo and not a lentigo maligna. And so, I agree. I would feel I could not serve my patients appropriately.
Yeah. And it's probably beyond the scope of the discussion here, especially over a primarily audio medium. But I wondered if you could talk a little bit about what kinds of things we look for in the dermatoscope so that patients can understand when we're sitting there and we're putting that cold glass on their skin 100 times on their back. What are the unique things that we might be looking for so they understand why sometimes this takes a little while, why we might be taking photographs through the dermatoscope to better inform our decisions?
Yeah, great question. So we are looking at many different structures that you cannot see with your eyes. So when you first look at a skin lesion, we'll just take a pigmented lesion without dermoscopy. You first look to see if it's organized or disorganized, right? So that's what clues you in to look at something. To me, all melanocytic lesions, whether they look organized or disorganized, require a dermatoscope. So when we apply it to the skin, we're kind of doing that with our, when we're looking through the dermatoscope, we are assessing what the architecture of the pigment network is. Is it irregular or regular? We are assessing what kind of blood vessels are present within it, some which are reassuring, others which are concerning for malignancy. So reassuring, if we're looking at a mole, there's something called comma-like blood vessels, right? Very normal and comma-like, so easy to remember. But if you see what looks like a dermal nevus or mole, and there's dotted and linear vessels in it, that should clue you in on a uniform appearing lesion that could be a pink melanoma in somebody. Other structures that we look for that are only present in, say, polarized dermoscopy are things like shiny white lines, and blotches, which they can show us alterations within the dermis of the skin, and we cannot see that unless we are assessing it with that scope. And not only that, it's also how much pressure and how we rotate the scope as well. So when we look at, for instance, total body photography and all of the current technology that is out there right now, looking at 3D renditions and not in-person dermoscopy, but full body dermoscopy. There are many things that you are doing with the device itself to render accurate information. So if I didn't have multiple captures, I would not be able to tell if it was okay.
And that seems similar to when somebody's looking at a CT scan, a radiologist, for example, they're going to look at a sagittal view. They might then turn it and look at a coronal view, and they will rotate the image and look at it from different perspectives to get a full picture as to what that lump might be inside the body. And we do a similar thing in dermatology to get a more accurate picture of what this little bump on the skin might be.
Yeah, agree completely.
So what was it that drove you into a passion for dermoscopy? Because everybody learns at least somewhat, in residency now, but it's something that you've truly become an expert on. I learn from your videos every day when you're posting them. And sometimes you'll post basically a question, and I have to wait till tomorrow to get the answer. And I'm like, I need to know now.
Right.
So why did you get so interested in dermoscopy?
So great question. So this is going to go just briefly into my background a little bit. So prior to a fairly untraditional path to school in general, what got me interested in medicine was I was a personal trainer 2 decades ago now, and I wanted to learn more about how the body functioned. And so I was very big into health, preventative medicine, cancer biology, cancer metabolism. And when I was in medical school, I was kind of very clued in on looking at screening guidelines for standardization of disease, whether it was breast cancer, prostate cancer, colon cancer, hypertension, your lipid levels, what your lipoprotein levels should actually be, what's considered normal and what is considered optimal. And at that time, when I decided dermatology was the field that I was going into, and this was 2 years prior to finishing medical school, I wanted to become the best possible person to utilize a tool that I can prevent somebody from dying from a disease, right? And in our specialty, that really comes down to the most common, more malignant tumors, melanoma, and dermoscopy was that kind of gateway to be able to help people prevent them from a early demise from what I look at as mostly a preventable disease. Some melanomas, I had a patient earlier this week, she had a melanoma of unknown primary. That is not something that in this current day and age we are able to screen for, right? But for a melanoma that is arising on the skin, we should be able to screen for all of those. So that really pushed me towards dermoscopy.
Yeah, that makes total sense. And that really, sounds like the passion for dermoscopy really stems from kind of a wider view on health. It is something that I think more people are interested in today than ever before, on trying to understand root cause of disease, how to prevent things, how to catch them early. And I wanted to give you the chance to kind of speak to the broader philosophy about this for disease prevention and detection at earlier stages.
Okay, so looking at like all diseases,
yeah,
general?
even
Okay,
getting
perfect.
outside of dermatology,
So
because this is something that I'm passionate about as well.
yeah,
I know that
so
you are. Our skin is not there in isolation. We have
yeah,
so many different systems that interact, and the skin can be a window to other things that are going on inside the body. But there's a lot that we do pay attention to as dermatologists.
right, I agree. And so just looking at, I think this comes down to like, how do you optimize healthcare in general, and where I look at why dermoscopy is essential for healthcare optimization from the skin side of it. But looking at like optimization in general in medicine, I look at, if you see your PCP, your primary care, and this is just standard as of today, and you get your LDL and your LDL says 100, right? What are they going to say to you? They're going to say,
You're fine.
You're fine. 100%.
Yeah.
They're going to say that you're fine. And the wrinkle with that, when you get a standard lipid panel, your total cholesterol, most of that information that's in there, the most imperative stuff, the triglycerides are important. That looks at really your metabolic function. But when you're looking at the other components, it doesn't tell you truly what your apolipoprotein B is. That those are essentially that is what you need to lower when it comes to your cholesterol, right? And then it doesn't tell you what your other risk factors are, like your lipoprotein A, which if you have an elevated lipoprotein A, you have an increased risk of a heart attack, even if you do not have any other, risk factors,
right?
High blood pressure, if you're diabetic. And so, your doctor, not your doctor, but when they're taking care of you, they're doing what is standard. That does not mean that is what is optimal, right? It's just like when we look at colon, getting your screening for colon cancer. It keeps becoming earlier and earlier in life. Why is that? Because there's still a subset of people that are not being captured, and health optimization in screening tests should be trying to capture everybody and identifying all of the disease that can be preventable.
One of the criticisms that I've got in speaking about this, because I've done a Prenuvo full body MRI, I've done extensive labs through Function Health. I looked at my genetic markers that might even tell me a risk of arrhythmia at some point in the future.
Yeah.
My LP(a), I've had that measured twice. My ApoE4 to determine my risk of Alzheimer's. I've done the GRAIL, blood test looking for cancer markers, which is something you might consider doing every few years. But how do you balance? How do you balance this proactive approach to health that goes beyond what is the standard of care and the risk of like false positive results and unnecessary testing? Because that's where the standard medical community and many consumers, at least in my comments, have pushed back, saying this is bad to promote.
So I think that some of it some individuals, and I will say that it is the people that are making noise negatively are in the minority. Okay. If you ask most patients, like for instance, there's a gene expression profile test for melanoma. I've never had a patient say they did not want that test done. And the reason why, I gave them prognostic information if we need to provide further kind of risk stratification. I've never had somebody say no to that. And my personal opinion is I would want to know that information, not looking at the cost of the test, just looking at, is this important to me or not? There are some things, like you said, Pronovo, looking at full body MRI, you have to be comfortable of identifying some incidental findings and what are you going to do with that? Because that may be present there. But the counterbalance to that argument is, what if there is a, biliary carcinoma that is a dot? What if there is a pancreatic tumor that is truly a dot? And looking at circulating tumor, DNA, the Galleria test. Why is that important? Well, if you find something before it is making a mass production in your body and growing massively, you may be able to intervene and save some of these lives. So I personally, I do these things that you do. And I think that that is very important. That component, when we look at health, full body MRIs, looking at doing circulating tumor DNA, I think is important. But the other stuff that is really low cost, a lipoprotein A, $4 to $7 test, right? That should be a once test for every person. Actually, I was talking to my wife recently. We have kids that are similar age, and looking at like screening. Well, it doesn't usually change much. Order that test on our kids, see if they have an elevated risk. It's very cheap, inexpensive to utilize, and it'll show me that what their risk is. Everybody should be having that test done, right? Every woman that is 40 years old should be not only getting a mammogram, they should be having twice yearly, instead of a standard once a year test, they should be having a diffusion weighted MRI to look at the density of the breast tissue, and they should be getting a mammogram. Those are easy things to do, and that can prevent stuff, for instance, that one test can see and the other one can miss. So my personal opinion is we should be making the things that are optimum standard, in particular when a lot of those things are at lower cost. Lipoprotein B, super low cost test. People have elevated, what they consider as elevated. They need to look at the data. It's not over a decade. When you look at a Framingham risk score, you're looking at 50 years, right? We're 40, you want to live to 90. You're looking at a 50-year term. Cholesterol accumulates. You want to lower that accumulation. So you want to put yourself in a better chance not to have an event that ends your life early.
Yeah, 100%. This really, to me, speaks of this, how critical it is in today's day and age for individuals to advocate for their own health, to be proactive. And you have to, whenever possible, work with a physician that understands this as well. And every physician that I know would love to be able to do all this stuff, but the incentive structures of the medical system today do not permit most family medicine physicians from being able to do this with their patients. And that's why it's so imperative for consumers to educate themselves on this and to seek that out. And it's easier than ever to go and get these tests. I don't get paid anything from Function Health, but it's what I have seen, one of the easiest ways to say, I want this test done. You can just select it online, pay for it, and go and get it done. And doing this, my perspective is that don't wait until you're in crisis and expect that the medical system will get you back in ship shape, because when things start to spiral, it's not always very easy, and the medical system has problems. We all know this. Medical errors are a thing, and if you don't be proactive about your health, you have no guaranteed outcome. And you don't have a guaranteed outcome even if you are proactive, but things often go better when you are proactive and educated.
Very much so. I mean, it's all about being prepared, right? Yeah. Preparation is so dang important, and you cannot prevent everything. You cannot prevent every accidental, injury, but you can try to control the controllables as much as you can. And I think that, like you said, being proactive, and look, this is me as, just go back to myself as a physician, when I was talking to my primary care this a few years ago, because a lot has changed and they didn't want to put me on a blood pressure medication because my blood pressure was in the upper 120s. And I said, no, that's not what the SPRINT trial shows. Like, we look at this and it's actually an elevated risk. And 2 months ago, I can't remember what governing body came out and, said, well, no, now ideal blood pressure is under 120, ideal, And so it's like, well, now, the data, it just takes time, right? It takes time for those guidelines to come. And then you really have like a decade later for people to start to adopt them.
So as we look at this optimum versus standard, right now, the United States Preventative Services Task Force that makes many of the recommendations for preventative screenings like colonoscopies and mammograms, they have not yet recommended full body skin exams as a preventative way to detect for skin cancer. There are a couple of states, I believe Illinois and Florida, thanks to the work of Dr. Amy Derrick, who now do require insurance companies to pay for an annual skin cancer screening exam. Some insurances, some employers may choose to do this. In my state of Idaho, it's not standard where every insurance company will pay for a screening exam. What would you say to people? When should they go get a screening exam, even if they have to pay out of pocket for it?
Yeah, great. This is a question I get asked all the time. So I think there's a few factors. Once you're in your 30s, I think you need a skin exam. That's my personal opinion, whether you have, 3 lesions, 5 spots, and they don't have to look irregular. I just think that it's reasonable. I've diagnosed, albeit basal cell carcinomas are very generally easy to treat as skin cancers. I have diagnosed countless melanomas in people who would have no idea that that was a melanoma. And to me, that is a person who was at risk, and all of the guidelines would not show that they were actually at risk, right? And then I think the other variables come into play that are more personal when you look at, so if there's family history in a horizontal, so brother or sister, or a vertical relative parent or a child, that you typically in insurance will cover that usually. If you have that first degree relative, I think that it's reasonable that you should probably get a baseline. I have a lot of patients who come in their early 20s or even in their late teens. Now, I'm not advocating that needs to be done always, but if you're worried, it's a very quick, easy test to do. But if you're in your 30s, and even if your insurance says, well, this is not a coverable expense, my personal opinion, based on what I've seen, is that's when it should start. It should start pretty early. And if you've had numerous sunburns, if you tanned, if you have a lot of atypical moles, you should consider getting skin checks without a doubt.
I think that matches up pretty well with the kind of advice that I give. First degree relative, you can basically start anytime and have a good relationship with your dermatologist. If you're 15 years old and a parent had a melanoma, you get a baseline. Maybe the recommendation is 2 years. Now, for medical legal reasons, it's hard to say go more than 1 year. But you just need a relationship with a dermatologist and work with them to get educated, because a lot of those exams, I find nothing. And then we just talk about how do you know when to come back and how to do these self-skin exams. And along with these self-skin exams, I think that we're seeing a continual growth with telehealth, with the implementation of AI. Do you see a future role for home dermoscopy and AI/telehealth as helping patients to screen themselves better?
I do. I think that's, and I have a slight conflict of interest here. I mean, I worked with a company. I published a paper back in October of last year, looking at AI and dermoscopy. And it was with a particular device. I'm not going to discuss the tool itself.
Yeah, but you're welcome to share if you'd like to.
Yeah. So the company is called Slip, and it's it goes essentially on a phone. So it slides on the back of the phone and it renders fairly decent images. When we look at like the difference between, say a DL4 or DL5, the images quality is going to be different, but it is much improved from one, sending a photo of your arm, right? Yeah. To your dermatologist, and 2, there is an AI component. That component is still being worked out, essentially, but that technology is coming to where there's an AI component that will be able to say of concern, not of concern. Now, granted, and this is unrelated to our data sets, this is just in general. My personal opinion is AI, great, verify, right? So always, if something is being screened, looked at, you're going to want that to have verification that it is truly inert or benign, not harmful, over just what a tool is saying that this is benign. But the telehealth component of being able to render those images, now it's not going to be able to give you everything. It's just like you said, you're the radiologist doing a sagittal versus, coronal plane. They're not going to be able to see it, but there's a lot that I can look at from a dermoscopy photo. As you know, I post those dermoscopy cases on my Instagram that you can look at, and you can get a pretty good rendition if that's concerning or if it's not concerning. So I do, it's an interesting space. I do think that we are moving in the right direction in that regard, and that will help with access.
I think so too. And I think it's an important part where dermatologists, we sometimes we feel like a lot, there's a lot of us, but many areas of the country are not well served by dermatology. And I think these tools will play an important role. And it is something, I like that idea of trust but verify, because this can be a helpful tool, but in the end, you never want to hear a story of somebody getting a report from AI alone that said this is fine, and it ends up being something bad.
Right.
So I think that's wise advice.
I agree. Yeah.
I want to touch on sunscreen for a minute, because we have genetic components that we don't always have control over. We talked about ways you can test for melanoma-specific genes. We often look at sun exposure as the main modifiable risk factor that we have in the prevention of skin cancer. There's chemical sunscreens, there's mineral sunscreens. There's so much debate online about the safety of one versus the other. And there's this idea that I like to call the illness industrial complex that uses fear to get people to make decisions, to maybe avoid sunscreen, that you need more sunlight. I want to know, what's your philosophy on that? How do you approach it? What do you use personally in your risk prevention strategies when it comes to skin cancer?
So I would say that what I personally use, I use both chemical and physical blockers. And actually some of the sunscreens, which they are not from the United States, are just only chemical blockers. The physical blockers in the United States they're good, right? So titanium dioxide and zinc oxide, and then ferrous oxides, looking at more for pigmentation. They both are fairly good at UVA and UVB, but if you look at longer wave UVA1, so 370 nanometers, 400 nanometers, and that's where zinc oxide is superior to titanium dioxide, there's a big gap in the blockage of UVA1, and that's where the chemical blockers come into play, right? That's where avobenzone, which is created in 1980, that is the main staple of looking at UVA coverage that you do not get from the physical blockers. So for me, in the United States, to have a truly complete sunscreen, you're going to have an integration of some chemical, and it could have physical blocker within it. Looking at the safety profile for what is currently on the market, I think that there was only 2 sunscreens that are considered GRACE appropriate, and that's inorganic, so zinc and titanium dioxide. Ferrous oxides are actually not listed on that through the FDA. And then, so that's category 1 GRACE, and then category 3 are the rest of the sunscreens that are on the market in the United States. And that means that they don't know if they cause harm. But there's no evidence that shows that it causes harm, but that they're still in this unknown zone of, well, it's absorbed, so since it's absorbed, does it cause harm? Well, the chemical blockers that are currently on the market, as I stated, the last one that was actually readily available was from 1999. So it's been over 20 something years of data. I think that they're pretty dang safe to use. And there have been many safety studies that looked at, for instance, how much looking at avobenzone in particular, how much avobenzone they fed to a rat, how much topical application of avobenzone would be needed to potentially even cause harm. And some of the data looks at, well, you'd have to coat your whole body every single day in a ton of sunscreen, and you'd have to do that every single day continuously for over 30 years for it to maybe, not even, they don't even know, maybe induce anything. And so to me, like I'm right here, I'm drinking a Red Bull right now. Okay. Diet Red Bull. So aspartame, big villainized chemical, and the amount of aspartame, I'd have to drink like 50 of those Red Bulls, because this is a small 8-ounce can, not a 12-ounce can, to have a potential negative consequence from the aspartame consumption. And I'd have to do that for 5 decades, and we don't even know if it would hurt you. So,
well, the caffeine would get you before aspartame did. So
there you go. Yeah, correct. Yeah. So,
no, I think this has been incredibly informative, and the approach that you take with preventative care, optimum versus standard, is very much in line with the way that I think and what I want my audience here to consider as they make choices for their own health. Highly encourage, if you're seeing a dermatologist, to have one that uses dermoscopy. And just like there's grades of expertise when it comes to using a stethoscope, there's grades of expertise when it comes to using dermoscopy. It's an area that I'm always seeking additional education on. So given that, you've got this incredible area of expertise, successful practice, you're catching skin cancer at earlier and earlier stages all the time. What was it that drove you into posting on Instagram? Why did you take what you know with your patients and go on to Instagram to educate the dermatology community and the consumers at large through social media?
So that's a great question. And I will say the biggest reason why I created this kind of initiative was I wanted to start educating other dermatologists, not so much patients. It was educating other dermatologists and dermatology providers, people who provide dermatology care, that the difference between what somebody who uses and is very proficient at dermoscopy and what the standard was. And how I became kind of privy of this data in Arizona, melanoma, like other diseases, for instance, like syphilis is reported to the state, HIV is the state, it's required to report. Well, melanoma in Arizona, it's a state requirement. So if somebody gets diagnosed with melanoma, in situ or invasive disease, it has to be reported. And so the diagnosis is reported as well as the treatment. So they kind of try to track what happens to an individual who has melanoma in situ. Do they live? Do they die? How does this progress? So it gives us good data sets. But in that report annually is provided to dermatologists here. So my first full year in Arizona was in 2020. And I don't know, I can't remember, I was at the top, and that came out in 2021. So I got the report in 2021. And I think I was either number 3, number 4 in the state. And there were some inaccuracies in the data sets because I worked at 2 practices. So it created this, I called the state and said, this is not perfect data, but it was showing where I was and where the average was. Flash forward to 2023, I identified 215 melanomas in the state, and the state average was 17 melanomas per provider. Ooh. And just wild, right? So a huge gap. And I said to myself, what can I do that can better, how can I serve patients better? And it's by showing people what you may not see and you think is okay. We're missing this stuff, and it's not intentional. You're not intentionally trying to overlook something, but you just are. And that was my personal call to action of, okay, I have to instruct. I mean, I go and I present at conferences, but what can I do that is easy and that I can, test people, and not really test them, but give them, I always looked at, questions as well, a way to check my understanding. And through Instagram, it's very easy to do that. Here's a photo of a case. What is this lesion? And if you get it wrong, who cares? I get stuff wrong all the time. I do a biopsy and it comes back negative. Okay, I thought it was a skin cancer. It was not. But it is to, I utilize that to say, how can I help other dermatologists and dermatology providers better care for their patient? Because there's a massive gap in this area, and I'm trying to close it. So
Yeah, it's not plausible to think that your population of patients are at such a greater risk than the average population of dermatology patients in Arizona that you would be well over 250 versus the average being 17. So that's scary to think of as a dermatologist. And anytime I go, a longer period of time where I haven't had a melanoma come back, it makes me worry. And I think, how many melanomas have seen me that I haven't seen? And it's something that's why I love the education that you put out. Can't thank you enough for it, and hope that many other dermatologists continue to find that. Definitely want to come and listen to your lectures whenever you're speaking at AAD or anything like that.
I would love it, man. I would love it.
Can't thank you enough for all the incredible information that you shared, for whether it's dermatology providers or even just the average consumer who want to understand more about what you do, your approach to medicine. Where can they find you online?
So I'm really only on Instagram roughly. So it's Michael_Christopher_MD. That's it. But I probably will start building out a little bit so that I can have some crosstalk, but mainly Instagram.
Yeah. Well, we'll share a link to that down in the podcast show notes and the video description on YouTube. And if you're interested in learning more about dermoscopy, definitely check out Dr. Christopher's information. His content is worth its weight in gold. I don't know if you can say that on social media, but it's incredibly valuable. And they're videos that I look for every day, and I love to repost and share. So Dr. Christopher, thank you for your time and expertise. And we'll look forward to catching up with you, hopefully in person next time.
Yes. Thanks for having me on, Dr. Portela. Appreciate it. Take care.